G'day and welcome to the lung ultrasound component of the WACS ultrasound training. In this talk we're going to cover all different parts of lung ultrasound, however we will not be specifically covering traumatic pneumothorax as that was well covered in the EFAST talk. So although there are medical pneumothoraces, the principle is exactly the same, so I'll refer you back to that last talk if you want to know about pneumothorax. It can be really useful to divide the chest up into 6 zones per side. This is pretty standard and the zones are labelled 1, 2, 3, 4, 5, 6. So 2 at the front, 2 in the lateral part of the chest and 2 posteriorly. So that's generally how we label our lung pictures, just so that everyone knows where it was you saw what you saw in the lungs. Now obviously these are pretty large areas, but it just gives you a bit of an idea as to how we go about it, and also helps you with the idea of pattern recognition, because I'll come back to that again and again with lung ultrasound, is that this is all about pattern recognition. Now when we do pediatric lungs, which is particularly useful, I tend to think of it as 3 separate areas. So there's 6 zones. So the first sweep goes from the posterior costophrenic angles up into the upper posterior chest, and it can be really useful to get the kid or the adult even to cross their arms across their chest to pull the scapula out of the way, so you can get a nice straight line up along that paravertebral region and get a good look at the lung all the way up. The second zone I look at is high up in the axilla, so the right middle lobe and the lingula on the left tend to collapse into that right axillary area and the left axillary area respectively. So you need to get the probe quite high up in the axilla to see the middle lobes. And then on the front of the chest, we generally start at the clavicles and slide our way down towards the diaphragm, as is what we do in trauma. So those are the 3 sort of sweeps that I do in kids. Now when scanning lungs, you really want to try and keep your probe perpendicular to the surface of the pleura. Now the pleura is obviously a round surface, so as you move your probe around on the chest wall, you need to keep changing the angle constantly in order to keep that beam hitting the pleura perpendicular as possible in order to optimize the artifacts. So when we're looking for artifacts in the chest, we use the lung preset usually on most ultrasound machines, and that makes the machine pretty dumb. It gets rid of a lot of the compounding and harmonics and basically gives us a very grainy picture, which doesn't look great, but it is actually really good for optimizing the visualization of artifacts. But artifacts do rely on you hitting the surface of the pleura as perpendicularly as possible. So you just need to get into the practice of moving the probe and keeping those angles sharp. Now if you do see something such as an area of consolidation or an effusion or something that's actually physically present within the chest, it's not an artifact, then it may be useful to switch the probe over to an abdo preset, and then that is better for looking at actual true structures within the chest. But the artifacts are not actually true structures, they're just reflection artifacts, or reverberation artifacts I should say. So let's talk a little bit about the lung artifacts. So A, B and C. So A lines are these horizontal lines which start at the pleural line, and each line is essentially a reverberation artifact coming off that pleura, and they're equally spaced down into the chest, and this is what you see in normal lung. You can also see this in pneumothorax if you remember from our last talk, but this basically tells you that there's a very solid reflective surface there at the pleura with air behind it. You don't know if the air's in the lung or in the pleural space, but the reverberation artifacts tell you that this is normal air interface. Now, A-lines are also a bit of a quality control, because if you aren't hitting that pleural surface nice and square on, you haven't got your probe perpendicular, then the A-lines will tend to fade and you won't be able to see them very easily. So it can be a bit of a clue that you need to sharpen up your angle to make those A-lines stand out, and then you know that you've got your probe in the right orientation. Now, B-lines. B-lines are abnormal. So B-lines are vertical reverberation artifacts, and these start at the pleura and they go all the way off the screen. So they should go all the way from the pleural line all the way off to the far field of the ultrasound. They should also obliterate the A-lines, so that you may still have A-lines, and as you sweep across, as these B-lines move with the respiration, they should obliterate the A-lines. So just make sure that you're seeing true B-lines and not very short comet tail artifacts, which are just a few millimeters off of the pleura, because those are generally normal, and it can be normal to have 1 or 2 B lines, especially in older people. And then the C is what we're looking for, is what we call consolidation or collapse, and we'll show a few examples of that later. All right, let's have a look at this normal lung sliding. So as you can see here, we have a rib and a rib with a nice shadow behind it. You're seeing a small section of the pleura up the top here, and then coming down you've got a nice reverberation artifact, nice A line, and another one off into the distance. And as that plays through, I'll just play that again, you can see these little short comet tail artifacts which probably don't make a beeline, and you can see these commonly, particularly in people that have had previous infections or scars, but those aren't B-lines. They have to go all the way off the far field, and they should obliterate the A-lines. Remember, A-lines are usually a normal lung profile. However, you can see this in someone with asthma or COPD. A large pneumothorax would look like this, or if someone had a big bullous, this would look exactly the same. It's just telling you that there is a nice, crisp, clean pleura-air interface, which you don't know if that air is in the lung or outside the lung. Okay, these are B-lines. Let's just play this. As you can see, here's the pleural surface. We've turned the probe a little bit oblique here, so we're getting more of the pleural surface and less rib shadows. And each time we play this, you'll see that these little B-lines, very long reverberation artifacts that go all the way off the screen. They obliterate the A-lines, and this would be abnormal. Now, when it comes to B-lines, what you need to then ask yourself is this a focal process? Is this a diffuse process? Is it at the bottom of the lung, so it's just in the dependent parts? Is it symmetrical? Because these are all clues where we get our pattern recognition to help us make the diagnosis and integrate it in with the clinical picture that we're seeing with the patient in front of us. That's how lung ultrasound works. There's no such thing as just a simple clear-cut diagnosis with lung ultrasound. Once again, another example of B-lines. These ones are quite confluent. They're almost solid in their appearance. And as you play that clip through, you'll see that that pleural line, it's a little bit ragged. It's not nice and smooth like it was before. So in my mind, this would make me consider something a bit more chronic maybe, or potentially infective, as opposed to APO, which generally keeps you a nice smooth pleural surface. So look at the pleural surface, look at the B-lines. Is this a nice smooth looking pleura? Is it a bit rough? Just gives you a bit of an idea as to what's going on. But this is reasonably confluent B-lines, so whatever process is happening here is quite fulminant. Now, we talked about pattern recognition, and this looks like a really complicated diagram, but it's actually not that hard. This was based on the original Blue protocol, which was written by Lichtenstein and co. Over many years. It's been modified and simplified. But what we basically do is, the first question is you put the probe on, you look and see, is there any lung sliding? And if there's no lung sliding, then you basically need to think about a couple of possibilities. One, you've got a pneumothorax at that point, and you go down the right-hand side of the diagram there. If you can't find a lung point, it's not clear-cut, but if you can find a lung point, as we said in our FAST lecture, that makes it almost 100% true that this is a pneumothorax. So that's no lung sliding and no lung, and looks like a pneumothorax. However, if you've got lung that's really inflamed or stuck or scarred, it also won't slide, in which case you may see the B-line profile with no sliding, or you may actually see consolidation, something that looks like pneumonia in that area, and that makes you think of pneumonia, although severe ARDS could also give you that picture as well. On the left-hand side of this diagram, we have normal lung sliding, so as we look at that pleural surface, we can see the two pleural lines sliding over one another. And if you've got a predominantly A-line profile and the patient's looking quite short of breath, that makes you think more along the lines of asthma or COPD. So you listen, if there's a wheeze, then that makes you think that's what that is. And we haven't seen anything that looks like a pneumothorax, then that's probably the diagnosis. However, if you have a predominantly B-line profile, and it's particularly if it's towards the bottom of the lungs, then that may make you think about something like heart failure. So that will tend to give you lung sliding, B-line profile, and that will make you think of heart failure. Whereas if you have a B-line profile with some consolidation, a ragged looking pleural line, then that may make you think of things more like bronchiolitis or pneumonia, and we'll talk a bit about some examples of this in a minute. But once again, this is all about pattern recognition and helping you find out what's going on. This is adding to your clinical exam and your other history. I really like this picture. So this is a picture of a pediatric pneumonia. As you can see, we've got the kidney on the right of screen. You can see there's some B lines coming just above the kidney, which are reverberating off of the pleural surface. And then we've got this area of consolidation. So this big, deep surface here, which looks like another kidney almost inside the chest, or what we call hepatization, and then returns back to the B line profile as we go further up into the chest. Great picture because this explains what infection looks like on ultrasound. You may see a nice focal consolidation, and that makes it very likely that this is pneumonia in the right context. However, if you put the probe on and you see the B lines, it is a bit of a clue that this is like an inflammatory penumbra, an area of inflamed lung that's around a pneumonia. And sometimes we don't get that pneumonia straight off, and so focal B lines make me want to go searching to see if I can find that area of consolidation in the immediate vicinity. And obviously we don't always find that, but focal B lines in the kid with a fever and a cough and looks like pneumonia makes me think this is some progressive lung infection. And the beautiful thing about ultrasound is you can come back and repeat it in 6 or 12 hours, and you may see that consolidation developing without irradiating the child. So beautiful picture there, and just explains how pneumonia and the tissue around the pneumonia can look on ultrasound. Now this is a little bit tricky. There's these little things called sub-pleural consolidations, and by definition a sub-pleural consolidation is less than a centimetre in depth, and it slides with the pleura, and we tend to see these in kids that have a viral pneumonia or some sort of atypical pneumonia. Of course, they can happen as part of a process which then goes on to become a fulminant consolidation within the lungs and a lobar pneumonia. But often if you see these diffusely throughout the lungs, it makes me think more about a bronchial pneumonia. So here's an example. If this kid had a good story for an atypical pneumonia or a viral syndrome, and you were seeing these small subpleural consolidations happening from place to place, that would make me think that this could be a diffuse sort of pneumonia. COVID looks exactly like this, and there are many other viruses and atypical bacteria that can cause a similar appearance. So this particular appearance is most likely going to be an atypical pneumonia of some sort. Now, true pneumonia gives us what we call hepatization. So hepatization is essentially where the lung has consolidated and it takes on the texture that's very similar to liver or spleen. And I'll just play this clip through here. So you can see some irregular pleura with some B lines coming up at the top of the screen here on the left, and then this area of consolidation which has a posterior shred, so you can see the pleural surface or the normal lung which is collapsed around the pneumonia, gives us this appearance behind. So I'll just play that again. And it moves with respiration, and it's well and truly above the diaphragm. So this is a little focal area of consolidation. And if I see this, then I will be starting to think this is pneumonia in the right clinical context, and you go looking for other features to confirm this, such as an effusion or possibly some bronchograms. So this is what sonographic bronchograms look like. A big area of consolidation in this lung, which is right next to the heart, so you can see the heart beating away there. If you look very closely at this little streak here, you can actually see the mucus or pus moving up and down in the bronchioles as the patient coughs and moves. So if you see these dynamic air bronchograms with fluid movement within them, this is very, very suggestive of a true lobar consolidation, and we would be treating that child for sure. Let's talk a little bit about pleural effusions. So pleural effusions are really, really easy to see on ultrasound. And they're actually very common to see in children with pneumonia or in adults with pneumonia. So it's almost universal that people with a good going pneumonia will have a small anechoic pleural effusion just at that posterior costophrenic angle, and that's pretty much the norm for pneumonia. We don't normally see it on chest x-ray because it's sort of tucked around behind the diaphragm, but when you look with the ultrasound, it's quite common to see a small pleural effusion. So don't worry too much about those little tiny ones that are just in that posterior corner. If you want to get an idea of the size of an effusion, you can measure the maximum depth of the effusion and then multiply that by 20. So if you've got a 5 millimeter effusion, which is very small, and you multiply that by 20, that suggests there's about 100 milliliters of fluid within that hemithorax. And obviously, if you've got a 30 millimeter, so a 3 centimeter, 30 millimeter depth effusion, then you times that by 20, you get 600 mils. So you're starting to get up to a decent, moderate sized pleural effusion at that point. So always, you can look from the front, as is in this picture, or as I said before, looking at the posterior costophrenic angle with the patient sitting in the upright position can be very useful for identifying small effusions. As with all things in lung ultrasound, it's good to look for a pattern. So is this symmetrical? Is it the same on both sides? That would make me think more about a systemic process such as CCF, heart failure, renal failure. These are the sorts of things that can give you that. Is it anechoic, so a nice black transudate looking effusion, or is there stuff in it? Is it echogenic? Is there debris floating? Is there septation or loculation? That would make me think more about some sort of chronic process or an inflammatory process such as it developing empyema. Small paraneumonic effusions, as I said, are very common, and one of the signs that can help identify effusions is the spine sign. So when you look at the liver or the spleen, and then you look at the spine, which you can see as these bright white shadowing patterns at the back of the field there, that's the thoracic spine or the vertebral spine. And then if you've got fluid above the diaphragm, i.e. a pleural effusion, you can see the spine continuing north up towards the head past the liver or spleen, which is not normal. You shouldn't normally be able to see that. It should normally appear like it does in the no effusion view on the left there, where once you have air in the lung, it should obscure any further view of the spine. So if you can see the spine in the chest through the liver or spleen, that's not normal, and you can go hunting around to find the fluid that's allowing the beam to go through. Right, here's a X-ray of a very unwell child who's got high fevers, has been on antibiotics for 3 days and is not improving. The question is this an empyema? Well, the chest X-ray is not particularly helpful because this kid had whiteout of the lung yesterday and still has whiteout of that right side of the chest today. So ultrasound to the rescue. Here's a picture of this child's lung on the side, and as you can see, there's this large heterogeneous looking region here, which is an empyema or a developing empyema. So this is an effusion, but it's actually got all these loculations and grainy tissue. So it's not a nice black anechoic transudate. This is clearly an effusion that's got a lot of stuff going on in it. So this is most likely an evolving empyema. The depth of this effusion, if you look at the markers on the side here, is probably in that 3 to 4 centimeter range. Once you get up above about 3 centimeters or 30 millimeters, that makes empyema much more likely in a child or an adult that has ongoing infection or fevers and not improving with antibiotics, for example. That makes me think about empyema, particularly if you see all this stranding of fibrin starting to happen within it. This is a process that happens, and over time this will corticate to become a proper walled-off collection, which will need thoracoscopic drainage usually, or potentially operative intervention. So be aware of that. They don't always look nice and black, and if you see that internal structure, makes you think about empyema. Here's another couple of examples. Here's a chest that has a relatively anechoic effusion here, and then you have this other picture here. We can start seeing this, what we call honeycombing, or fibrin starting to collect and starting to form strands, and it's stuck to the diaphragm there. This makes me think about an empyema in this patient because they weren't getting better. They had a known effusion previously but had become unwell now with fevers, and the most common cause of empyema in patients like this is whatever it is that brought them into hospital. So this patient came in with MRSA sepsis, and then they were found to have this. So this is almost certainly a staph-related empyema, because these fluid collections are bacterial breeding grounds. So the best way of working out what bug it is to look at what else could be going on with the patient. But this one is certainly big enough that we could poke a needle into it, take a sample and send it off to the lab to confirm that this was in fact an empyema. Now, a quick little note about airway ultrasound, just while we're in the chest, and this is courtesy of my good friend Dr. James Rippey. So if you take a longitudinal slice of ultrasound through the neck, you can see the anatomy quite nicely. Actually, you can see the thyroid cartilage with its characteristic shape, and then you've got the cricothyroid membrane, which is the gap between the thyroid and the cricoid. The cricoid cartilage looks nice and round and proud, and then the small tracheal rings heading down into the neck. It looks exactly like what you'd expect it to, and this can be really useful if you're planning to mark out. I'll just play this short video.
This video is going to show the ultrasound appearance of the upper airway and transverse section. I begin at the upper thyroid cartilage and then descend to the mid and lower thyroid cartilage before going on to the cricothyroid membrane, then the cricoid cartilage, and then the upper trachea. Here we are at the upper thyroid cartilage, which is triangular in shape with steep sides. You can see the false chords moving there with inspiration and expiration. As you move down over the thyroid cartilage, it becomes less steep in the triangular appearance. Next, we find the cricothyroid membrane, and that's represented as this bright echogenic line, which is the air interface. So this is the cricothyroid membrane at its widest part, and we're still descending with the ultrasound probe. Below the cricothyroid membrane, you get the cricoid cartilage, and you can see we've lost that bright air interface. The cricoid is round. Then we get an air interface below the cricoid as we hit the trachea, and we lose it again as we go down and meet those tracheal rings.
Okay, now this is another short video which I find particularly useful as a post-intubation check. So traditionally we would listen to the chest and make sure there was air entry on both sides. However, we know that that's actually not particularly accurate, and in a very noisy resus that can be very tricky to do. So let's just play this video.
You're in a busy trauma and your residents just intubated the patient. Having said that, after the intubation, the SATs are really staying in the low 90s and the pressure alarm on the ventilator is going off. You realise that something's not quite right. So you pick up your probe. This is a curvilinear probe that's been placed on the left chest wall, and you look at what's going on there. At first glance, this looks like normal lung sliding, but if you stop and look closely and listen to the SATs monitor in the background going beep, 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 you'll be able to notice that these movements are timed perfectly with the cardiac pulsation. So this is the lung pulse sign of a normally expanded but non-ventilated lung. So that tube's gone down, most likely the right main bronchus, and you need to pull that tube back so that you can once again ventilate that lung. At this point you should leave the probe on the chest wall as you withdraw the tube, and you can confirm sliding once you've actually pulled the tube back past the carina and you're ventilating the lung.
Okay, so that's a really handy hack for post-intubation checks if you really want to know where that tube is before you go on and get a chest x-ray or have struggle to ventilate a patient. Alright, so that's about all we have for lung ultrasound. Please go and watch the instructional video and hit us up with any questions. See you next week. Bye.